million. The incidence is only 5 in 1 lakh population, and it accounts nearly for 15% of the primary brain tumor. So it is the third most common intracranial tumor next to meningiomas and diffuse astrocytic oligodendrogliomas. Significantly higher incidence it's a slightly higher incidence in female, rare in children, and 57% of the pituitary adenomas are non-functional and 43% are functional. So that depends on where the hormone tests are done and when and how it is done. So the prevalence may vary. When we talk about pituitary adenomas, the functional classification is as I described. It's derived from which group of cells. There are 3 group of neuroendocrine cells which are found in the pituitary. One is the T-PIT lineage, PIT1 lineage, and SF1 lineage. So we get acromegaly, Cushing's, all those things. Mainly the acromegaly, prolactinoma, all from the PIT1 lineage tumors. They are somatotropes and mammosomatotrophs, lactotropes, thyrotropes. If we get a gonadotrope adenoma, that is usually from the SF1 lineage, and if we get a Cushing's disease, the tumor is mainly from the T-PIT lineage. So this is a newer functional classification of the pituitary adenoma. Moving on to the structural classification, we always classify it as a pituitary microadenoma when it is less than 1 centimeter in size, the maximum diameter, and if the maximum diameter is more than 1 centimeter, we call it as a pituitary macroadenoma. So when you get a pituitary neuroendocrine tumor, you get it mainly because of an incidental finding. The patient would have come to you for a headache, vomiting, or visual field problem. You do a MRI for some other reason and you find out a pituitary tumor in that. Or the patient might have come for a problem which is related to a hormone deficiency or a hormone excess state, where you make a diagnosis of a pituitary adenoma in that patient. So for pituitary incidentaloma, suppose most of the times patient comes with an MRI saying that there is a report of pituitary adenoma, what to be done. In that kind of a report, probably I will advise would be confirm that it's a pituitary tumor, because many times you will be missing a diagnosis of hypophysitis, you will be missing a diagnosis of Rathke's-Kleffs if you blindly believe the MRI report, because the MRI is done for brain, it is not done for the pituitary sequence. Second, do a judicious hormone workup after confirming that it's a pituitary adenoma. Don't do all the hormones and don't leave any hormone which is required. I will talk all those things in detail. Involve an endocrinologist and a neurosurgeon, because all the pituitary macroadenomas or microadenomas need a multidisciplinary team approach rather than a single center approach, single person's approach. Avoid doing these things when you see a pituitary incidentaloma. Don't operate the patient even without a basic hormone test. I am still seeing patients getting operated, Cushing's, acromegaly getting operated even without a single test of cortisol or thyroid function in the pre-op evaluation. So that kind of a things it's happening even in Chennai, every place it's happening. And don't do growth hormone levels. Whenever someone is seeing a pituitary adenoma, the first thing is to order a growth hormone level. A random growth hormone testing or a fasting growth hormone testing is a waste of money. My CMC professor used to tell that it's an endocriminology. We are not practicing endocrinology. So don't do a random growth hormone or a fasting growth hormone test. And don't presume that the adenoma is cured by surgery unless proven. Many times patients lose to follow-up after surgery. They think that the adenoma is cured and they come with hypopituitarism after 5 years, 6 years with an adrenal crisis and all. Don't. It needs a lifelong follow-up. So when you talk about the differential diagnosis, there are n number of differential diagnoses. I am not going to discuss in detail how you can differentiate it. That's not the scope of this talk. But remember that all these things, Rathke's, subarachnoid cyst, primary CNS lymphoma, hypophysitis, all these things can be a differential diagnosis of pituitary adenoma. Talk to your radiologist. Find out it's only pituitary adenoma and nothing else, then proceed further. So what are the 4 simple steps? One is assess the functionality of the adenoma. When you confirm that it's adenoma, assess if there is any hormone deficiency, assess the extent of the tumor, and then go on to the management based on the first 3 answers. So how will you assess the functionality of the adenoma and the hormone deficiency? At least basic mandatory tests need to be done in any pituitary adenoma. The first thing, cortisol. Dr. Sridhar has alluded very well about the cortisol. I am not going to describe in detail. always remember doing a thyroid function test. Remember to include free T4, free T3. Many times in mastral checkup we see TSH, T4, T3, but when it comes to pituitary adenoma, we do only TSH and say that TSH is normal, so thyroid is normal. Because we know in central hypothyroidism, TSH will be normal, only free T4, free T3 will be low. So never miss free T4, free T3 in the workup of pituitary adenoma. Do a prolactin, do an IGF-1, because many times silent corticotropes, somatotrope adenoma can be missed if you don't do an IGF-1. In women reproductive cycle, do a FSH-LH estradiol. In men, do an FSH-LH testosterone. These are basic hormone tests will be required for any patient with a pituitary adenoma. Special tests are required based on the clinical situation. Suppose we suspect a Cushing's disease, we need to do an N number of tests. It's a big headache for an endocrinologist if you suspect a Cushing's disease. If you suspect an adrenal insufficiency, do a synactin stimulation, about which Dr. Sridhar has already told, not in an acute situation but in a chronic situation. Only when you suspect an acromegaly or a growth hormone deficiency, do a glucose suppressed growth hormone for acromegaly, because growth hormone is a pulsatile hormone. As I told you, random growth hormone has no value. Do a glucose suppressed growth hormone, and if you suspect a growth hormone deficiency in a child because of a pituitary adenoma, do a growth hormone stimulation test. So these are the only way growth hormone has to be checked in an individual. Always remember that in a macroprolactinoma, if there is a big tumor, you suspect a prolactinoma and you get a falsely normal or a little bit high value, suspect that there is a hook effect, because very high prolactin levels can falsely give a low prolactin when you do an assay. It's an assay problem rather than anything to do. So always do a prolactin test in dilution. Suppose you are getting a 2 or 3 centimeter big tumor, but the prolactin is only 80 or 100. Before confirming that it is not a prolactinoma, ask the lab to do a prolactin in 1 in 100 dilution to confirm that there is no hook effect. If there is a gonadotropin secreting tumor, you may need some special tests like free alpha subunit and TRH stimulation, which even as endocrinologists we rarely do. So that's just for the completion's sake. So when we talk about the functioning GH tumors, of course the non-functioning pituitary adenoma is the most common pituitary adenoma, I would say. In the functioning tumors, prolactinoma is the most common tumor, followed by growth hormone secreting adenoma, corticotrope, thyrotrope and the gonadotrope adenomas. So once you assess the functionality, once you assess the hormonal status of the particular patient, the next thing would be to go for a MRI imaging of the pituitary and not MRI imaging of the brain. Remember that, don't write MRI imaging of brain, write MRI imaging of the pituitary, because pituitary imaging needs special imaging techniques and not applicable for a MRI brain. It's a small size gland, it has very much involved, all the bones are surrounding the gland, and there will be sinusoidal air just below the pituitary gland, and there is an internal carotid artery on both sides of the pituitary. So these things have to be nullified, the effects have to be nullified to image the pituitary. So you need special techniques. Many times 1.5 Tesla MRI may not pick up a microadenoma, you may need to go for a 3 Tesla MRI. Fast spin echo imaging should be required, the slice thickness should be less than 3 millimeter. You may require a dynamic imaging technique to rule out or to confirm that it is a pituitary microadenoma, it's not something artifact or it's not a Rathke's cleft cyst. Many times we get report like 4 millimeter query adenoma, that kind of a report. So don't take it at its face value. Ask the radiologist to do a dynamic imaging, because they would have done an MRI brain and they would have found out an incidental finding as a pituitary adenoma. Don't think that it's a pituitary adenoma unless you confirm it with a dynamic MRI imaging. And sometimes you may need to go for a fat suppressed imaging techniques also. So unless we do most of these special techniques, the pituitary adenoma is not a diagnosis. So pituitary adenoma can be classified based on the two classifications. One is Hardy's classification, which is dependent on the older classification, depending on the size of the tumor. The newer classification is called as a NOSP classification. NOSP classification mainly involves how much the tumor is invading the cavernous sinus, whether it is touching the medial portion of cavernous sinus, whether it's touching the lateral portion of cavernous sinus, whether it's extending beyond the cavernous sinus. So tumors, pituitary adenomas have to be reported in both ways. They should report it with NOSP classification if it is a macroadenoma. If it is a microadenoma or a simple tumor which is just in the suprasellar extension, you can report it with a Hardy's classification. So grade the tumor according to any one of or both the classifications. Sometimes pituitary adenoma can present to you with apoplexy, and we should be able to identify that problem, because this the image shows a cut kind of thing in the pituitary where there is an apoplexy, and apoplexy will be an adrenal emergency. So adrenal crisis can happen. Dr. Sridhar has told how to manage the adrenal crisis. So finding out an apoplexy, identifying it is very important, otherwise adrenal crisis can become lethal in a given patient. So when you make all the diagnosis, like it's a micro or macro adenoma, it's a functional or non-functional adenoma, how to approach? There are 4 different approaches: wait and watch. Many times you will be surprised that we are telling wait and watch for a pituitary adenoma. So that is also one approach. Second thing is go for a surgery. A transnasal transsphenoidal surgery is a generally done surgery. We don't do transcranials nowadays, so it's not done except for craniopharyngiomas. Medical management, either it's a cell-specific means if it's a prolactinoma, we can try cabergoline. If it is a acromegaly or a growth hormone secreting tumor, we try lanreotide, octreotide, we try paciriotide. So cell-specific medical management, or a non-specific like temozolomide can be used in many tumors. Like there are chemotherapeutic agents which can be used for many tumors depending on whether they are, irrespective of whether they are producing which kind of a hormone. And radiotherapy is one of the other last options. So where all you can just wait and observe. Not all pituitary adenoma requires surgery. If it is a very incidental microadenoma, non-functioning tumor, less than 10 millimeter, there is no symptom, you just monitor them with an yearly MRI or even once in 2 years MRI. Even if it is a non-functioning tumor, it is removed from the optic chiasma, it is not touching optic chiasma, not invading any other structures, non-functioning, do a wait and watch approach. And even in prolactinoma, where it is less than 10 millimeter size, very mild prolactin elevation like 40, 50 in a postmenopausal woman, say 60 years of age, it is not going to increase, means just wait and watch. These are some of the clinical situations where you need not do a masterly inactivity is all what is required. Coming to the medical management of pituitary adenomas, we all know prolactin secreting tumor means cabergoline. This is the most commonly used or abused drug, I would say. And acromegaly, if is suspected, we can go for octreotide, lanreotide, pegvisomant. And then if it is an ACTH producing adenoma, we have to think about using ketoconazole or paciriotide. These are some special situations where we use these hormones or where we use these things. Coming to the common tumor, that is a prolactinoma, which is a functioning tumor. So prolactinoma, suspect a prolactinoma when the prolactin is at least above 80 or 100. Below 80, we generally don't take the tumor as a prolactinoma. Macroprolactinoma means that the prolactin level should be more than 200. So anything less than 200, think about other causes like stress, medications, hypothyroidism, renal, liver insufficiency, pregnancy, all those things. So no need to jump on the diagnosis of a prolactinoma just with a value of 50 or 60 of prolactin. So all high prolactin, suppose you are getting a high prolactin of say 60 or 70 and you are getting a query microadenoma in the pituitary gland, it doesn't equate to a prolactinoma. It may not be a prolactinoma. The tumor may be an incidental finding because all endocrine organs are nodular. If you randomly pick up 100 people here and do MRI, at least 3 or 4 people will be having a diagnosis of pituitary microadenoma. That doesn't qualify for a surgery, that doesn't qualify for an endocrine workup. Pituitary adenomas are quite incidental findings. So all high prolactin and microadenoma doesn't equate to microprolactinomas. You can get a very big adenoma but a mildly elevated prolactin, as I told you, as a hook effect. In contrast, you can get a big adenoma, prolactinoma, a big non-functioning adenoma but with a prolactin level of 80 or 90 just because of the stalk effect, because the adenoma will go and compress the pituitary stalk and that will elevate the prolactin. So you can have both the situations. You can have a false negative, you can have a false positive thing also. So it's only the clinical diagnosis which is more important, not the values which are seen in the papers. So in a micro or macro prolactinoma, medical therapy is the first choice of treatment. We need not subject them to a surgery unless there is a significant chiasmal compression or there is a risk of apoplexy, or if the patient is not tolerating the dopamine agonist or the patient is not responding to the dopamine agonist therapy, then we should think about going for surgery for a prolactinoma, even if it is a macroprolactinoma, because the response rate to dopamine agonist is almost 90% in most of the micro as well as in the macroadenomas. So prolactinoma surgery, only there are limited indications for surgery in a prolactinoma. Of course, if conception is planned in a prolactinoma, you can stop the dopamine agonist therapy if the MRI is showing a good response with the tumor, and you can monitor them with the visual field if it's a macroprolactinoma. Clinical monitoring is all that is required in a microprolactinoma. There is no need to do prolactin test, no need to do MRI during the time of pregnancy, because prolactin will be elevated naturally in pregnancy. In a microadenoma, prolactinoma in pregnancy, only clinical monitoring. In a macroadenoma, prolactinoma during pregnancy, visual field checkup is all what is required. Coming to the acromegaly, as I told you, if acromegaly, we can diagnose it by n number of clinical features. Do a IGF-1. IGF-1 is a screening test. If IGF-1 is high, go for a glucose suppressed growth hormone levels. If the glucose suppressed growth hormone, like just we do like a GTT, we do growth hormone at 30, 60, 90, 120 minutes. If the growth hormone shows less than 1, that is normal. If it is more than 1, then you make a diagnosis of somatotrope adenoma. Depending on the situation, you can either go for a medical therapy also. Surgery is not the first line. Nowadays, we do go for a medical therapy, debulk the tumor, then we go for surgery. Sometimes if the tumor is very big. So, that is one way of approach. Cushing's is a headache for the endocrinologist also. So, diagnosing, you need to go for a overnight dexamethasone suppression test, late night salivary cortisol, 24-hour urinary free cortisol, n number of tests as a screening test. Confirmatory test, go for the ACTH, go for a high dose dexamethasone or a 48 hours DEXA suppression test. You may need to even go for an inferior petrosal sinus sampling to diagnose if it is a microadenoma, if it is only a 4 or 5 millimeter size of tumor, if you are not able to localize the tumor in spite of confirming that it's a pituitary Cushing. So, Cushing's is a nightmare, leave it to the endocrinologist. Non-functioning pituitary adenoma, previously they were considered completely non-functioning. Nowadays, immunohistochemistry says that even in non-functioning adenomas, you can get 15% of tumors expressing corticotropes. So, a silent corticotropic adenoma or a silent Cushing's can be there in 15% of non-functioning adenoma. So, unless we do the immunohistochemistry, we may not know that it's a silent corticotrope adenoma. Again, if there is a visual field defect or if it's a imminent apoplexy, growth of the tumor, go for surgery. Even in non-functioning tumor, if it is just 1 or 1.2 centimeter, not touching chiasma, you can just wait and observe. Radiotherapy, the recent modalities are mainly the SRS, the small, that is the single fraction therapy and the proton beam therapy are gaining in a big way. But each kind of radiotherapy has a role to play depending on where the size, what's the size of the tumor and whether it is nearby the optic chiasma or away from the optic chiasma. And you have good results with the SRS as well as the proton pump therapy, but of course the cost is high. Traditional therapy, radiotherapy is still preferred. Coming to the last slide, this is the slide which summarizes what will happen after we do a surgery or radiation. That depends on what kind of tumor it is, what is the size of the tumor, what is the extent of surgery which is done. So, remission is not 100%, relapse is also not 100%. Everything is between 50 to 70% we'll say. So, a lifelong follow-up may be required for most of the patients who have a pituitary adenoma diagnosis. So, with this I conclude my talk and I invite you all for this P-Trendo meeting which we are going to organize on September 21st in Chennai in Hotel Green Park, Vadapalani. Please pass on this message to your pediatric colleagues also and please support us by sending more abstracts and participating in the conference. Thank you.